how can I not talk to you about suicide when I'm talking about emergencies in psychiatry? Suicide is an extremely important issue, right? Public health importance of suicide is no doubt extremely important. You need to know in India about 1,30,000 plus suicides happen per year. In 1 year, 1,30,000 plus suicides happen. In 2020, the suicide rate in our country became 11.3. 1 year before, it was 10.3. So almost a 1 point jump in the whole thing. And you know why it would have raised. COVID could be one of the major contributors, right? COVID could be one of the major contributors. Now, what you need to know is world over statistics says 1 in 40 seconds, somebody is succumbing to suicide. In 1 in 40 seconds, somebody is succumbing to suicide. The even more challenging news you should know is for every suicide which is happening, there is easily 20 times more suicide attempts. 20 times more suicide attempts are happening. Did you know the National Mental Health Survey, National Mental Health Survey in India said about 1 in 100 people have active suicidal ideas. 1 in 100 people have active suicidal ideas. So suicide is quite a common problem for us to deal with. So next, let's talk about risk factors. Male gender is an important risk factor for suicide. Especially if they are unemployed, it does increase the risk of suicide even more. Unemployed, it does increase the risk of suicide more. Family problems, marital problems, if that is going around in the background, I think that's one of the important contributors for risk of suicide. Mental illness in the individual is an important risk factor for suicide. What they also ask you in exam is few important points. Remember, 15% of the people with mood disorder can succumb to suicide. 15% of the people with mood disorder can succumb to suicide. 10 to 12% of patients with schizophrenia can succumb to suicide. 10% of people with substance use disorders can succumb to suicide. 10% of people with anorexia nervosa can succumb to suicide. 10% of borderline personality disorder patients can succumb to suicide. Understood? So 10%, 10 to 12%, and 15%. So mental illness presence does increase the risk of suicide. If you have access to means and methods, if there is access to means and methods, it increases the risk of suicide. What do you mean by access to means and methods? If they know how to succumb to suicide, or if they know what they want to do, or if they have dangerous weapons, like for example, if they have a gun access, they have increased risk of suicide. Doctors, for that matter, unfortunately, can have access to medications, right? So it does increase the risk of suicide in doctors, unfortunately. Understood? If somebody is feeling hopelessness, it does increase the risk of suicide. Hopelessness does increase the risk of suicide. If they have past attempt of suicide, it does increase future attempts of suicide. In fact, they've asked an exam, don't forget about it. The most important predictor of suicide is past attempt of suicide. The more severe the past attempt, the more recent the past attempt, the higher the chances of the individual succumbing to suicide further. So past attempt of suicide is something you should be seriously looking at and addressing. Getting it? When you're talking about mode, what is the most common method for succumbing suicide? As per documentation, the most common method is hanging. Hanging is the most common method. Next is poisoning. The third one is drowning. The fourth one is self-immolation. Self-immolation. Understood? Hanging is the most common method of succumbing to suicide. Some students look at some forensic books and say, is it not poisoning? Please remember, hanging is way more common as per the NCRB statistics. NCRB statistics is the official documented statistics of suicides in our country, and as per that, hanging is the most common mode of succumbing to suicide. Now, self-immolation specifically is more common in two scenarios. One, in young women, especially where there is a question or a possibility of dowry death or dowry related death. Understood? That is one place where self-immolation is common. Another place self-immolation is very common is political agenda. The third reason is some kind of hero worship. Some big star dies, they also self-immolate himself. These are the common places and scenarios where self-immolation happens in suicide. Understood? So when you're talking about managing suicidal patients, you need to understand you need to keep them in suicide watch. Means what? You should constantly keeping an eye on them. You need to constantly keep an eye on them and ensure they are safe and they don't have access to any means by which they can succumb to suicide. Treatment of the underlying mental illness is extremely important. ECTs are very useful strategy in patients who are extremely suicidal. Electroconvulsive therapy or shock treatment is an extremely useful strategy in patients who are extremely suicidal. Understood? In psychiatry, there are only two drugs which is known to decrease suicide risk. There are only two drugs which are known to decrease suicide risk. Which are the two drugs? I can hear you. Yes, lithium. Lithium is one and other one is clozapine. These are the only two drugs in psychiatry which we very much know can actually decrease the risk of suicide. This leads us to discuss about something called as paradoxical suicide. This was a question which was recently asked in an All India exam. What is this paradoxical suicide? You need to know. Now, when you're talking about paradoxical suicide, we are talking about SSRIs. SSRIs are antidepressants, right? And we know depression is one common reason why people succumb to suicide. Now, what happens in majority of them is when you give antidepressant like SSRIs, it decreases the depression symptoms and it improves the patient. But in a small percentage of patients, when SSRIs are given, what happens in the initial days? There is an increase in the suicidal ideas. Not only there is an increase in the suicidal ideas, they might sometimes feel more agitated in the initial few days or sometimes little more energetic in the initial few days, which can make them succumb to any of the suicidal thoughts they have. Now, knowing this, it doesn't mean you should not give SSRIs to patients. Please understand, SSRIs are very much recommended, but you should always tell the patient that if they feel any worsening of the symptoms or something like that, they should not be suffering by themselves or act on these impulses, but rather come and meet the doctor to change the medication into a different SSRI and see whether it is more effective and helpful to reduce the paradoxical suicide risk. Understood? So before we wind up the discussion on suicide, you need to know what is parasuicide. Parasuicide is nothing but harming oneself. harming oneself with no intention to die. The person is harming oneself with no intention to die. With no intention to die, that is what is called as parasuicide. That is what is called as parasuicide. Getting it? The other term for parasuicide is called as deliberate self-harm. It is called as deliberate self-harm. But what is the newer term for all these things? These are terms which have been removed. What is the newer term for it? Any idea? The newer term is non-suicidal self-injury. Non-suicidal self-injury is the newer term. NSSI. NSSI, non-suicidal self-injury, is the new term for para-suicide. They've asked this question in exam. Please remember, what is the most common mode of para-suicide? What is the most common mode of para-suicide? What do you think is the most common mode of para-suicide? The most common mode of para-suicide is slashing the wrist, right? Slashing the wrist is one of the most common methods of para-suicide. Who are the patients who might have parasuicidal behavior? Parasuicidal behavior is very commonly seen in EUPD, also called as borderline personality EUPD or borderline personality disorder. It is also seen in histrionic patients. It is seen in antisocial patients. Understood? It can also be seen as a part of patients suffering from depression. It can be quite commonly seen. These are some important places where you can see parasuicidal behavior, which is called now as non-suicidal self-injurious behavior. So let us talk about another important emergency kind of scenario which patients can land up in: catatonia. Catatonia. The most common reason for catatonia is mood disorder. Mood disorder. Mania is more common to lead to catatonia than even depression. The other reason for catatonia is it can be a part of psychosis. It can be a part of psychosis. The third important reason could be neurocognitive disorders, which is nothing but also called as organic brain conditions, right? Organic brain conditions. They all could lead to catatonic presentation. Now, when patients come with catatonia, they have very, very common set of symptoms. There are multiple symptoms which can be there. There are easily about 23, 24 symptoms which have been described to be part of catatonia. Let me highlight to you some of the important components of catatonia. How do you diagnose a patient with catatonia? First of all, patient will have mutism. There can be decreased oral intake. There can be decreased oral intake. More importantly, in many of these patients, they can also have posturing. Sometimes they can have something called as catalepsy. Catalepsy. What is catalepsy? Catalepsy is nothing but kind of a posturing where they might be standing in the same posture for a long time. So they might be standing like this for a very, very long time. That is what is called as catalepsy. Understood? They can also have something very important they have asked sometimes in exam called as psychological pillow. They can have something called as psychological pillow. What is this psychological pillow? If this is the bed, right? When we are sleeping, what happens? We have a pillow and we are lying on the pillow. The head is on the pillow, right? So what happens in psychological pillow? There is actually no pillow, but the person still remains like that. The pillow has been taken off. Then also they'll be in that same posture. That is what is called as psychological pillow, which can happen in these patients. These patients are classically known to have something called as automatic obedience. Automatic obedience can happen. What is this automatic obedience? If you put your hand into the pocket and suddenly tell your patient, okay, show me your tongue, I want to prick it with the needle. Normally, an individual who is normal would not show the tongue because you have told, I want to prick it with the needle. But what happens to catatonia patients? They'll have automatic obedience. Means what? They will still go ahead and show the tongue out. Understood? Show the tongue out. That is what is called as automatic obedience, which can happen in patients with catatonia. Patients with catatonia can have something called as waxy flexibility. What is waxy flexibility? When you move their hands and legs, right, you get a waxy kind of consistency. And that is what is called as waxy flexibility, which can happen in patients with catatonia. Patient can also have something called as Gegenhalten. Another one is called as Mitgehen. What is Gegenhalten? Gegenhalten means reciprocal resistance. What is Gegenhalten? Reciprocal resistance. When I put too much force and try to bend, they also resist too much. When I don't put much force, they also don't resist. So when I put more force, they resist more. So that's why it's called as reciprocal resistance, which is called as Gegenhalten. So what is this Mitgehen? In Mitgehen, even when you put little pressure, you can move their hand significantly. Even when you tell them you don't need to cooperate with me, even with little pressure, you can do it. That is what is called as Mitgehen. An extreme form of it is what is called as Mitmaschen. What is this Mitmaschen? You just touch their hand, or you bring your hand nearby and move it. They will still move the way you want. Understood? You just touch it, or you keep it near and do it. You will be able to move their hand, leg, their body in the way you want. That is what is called as Mitmaschen, where there is extreme cooperation, extreme amount of cooperation. Here, a little bit of cooperation happens. Understood? These are terms which have been asked in exam, so it is good to know. One more term which they have asked in exam, which is good to know, is something called as angel poise lamp. What is this angel poise lamp? Where do you see angel poise lamp? You see in catatonia patients. Do you know what is this angel poise lamp? You go to Google search and type angel poise, you'll get to know. But I know that all of you know what is an angel poise lamp. Don't you have this kind of a lamp, which you would have seen at least? It'll go like this, it'll come like this, it'll come like this. Then there'll be one light. So you can bend it, right? You can bend it. Here also you can bend. Here also you can bend. Here also you can bend and position the light you want the way you want. This is what is called as angel poise lamp. Why do they call it as angel poise lamp in catatonia? Is in catatonic patient, right? You can move their hand in various ways and leave it like that. And for hours together, they will be in the same posture. If you keep it like this, they'll be like this. If you keep it like this, they'll be in this. So that is what typically happens. Like an angel poise lamp, where you change the position and leave, the lamp will remain the same. Catatonia patients can also remain the same. Now, over years, catatonic presentations have reduced significantly. And nowadays, with more treatments being available and earlier interventions, catatonia presentations have come down a little bit, but still can be one of the important emergency presentations. What is important for your exams also to know is how do you manage these catatonia patients. This is where you need to understand many times it can be requiring antipsychotics because it is a psychotic symptom. If it is also because of an underlying mood disorder, you need to give antidepressants or mood stabilizers. You need to give antidepressants or mood stabilizers. The more important point you should know is 2 points. There is something called as lorazepam test. Which is extremely important. If you give lorazepam injection or even oral if the patient is taking, right? Within 48 to 72 hours, you will see an improvement if in majority of the catatonia patients. In majority of the catatonia patients, you can see an improvement with giving lorazepam within 48 to 72 hours. If you don't see benefit, if you still want to manage a patient with catatonia, then is when you consider what? You consider ECTs. ECTs are a useful strategy in order to manage patients with catatonia, and they respond very well.